being the Associate Dean for Educational Research and Innovation here at Rutgers School of Nursing. A few housekeeping tips before we begin. We will be recording this session, and you may find the session recording and session materials posted about 48 hours after today's session. If you have any technical issues, please type into the chat, and our team, Dr. Jeanette Manchester and Marielle Rosario, will assist you. If you have a question for the panelists, please, there's Dr. Manchester. Dr. Manchester. And if you have any questions or comments for the panelists, please type them into the Q&A function located to the right of your screen, or hover over the bottom of your screen and click on the bubble icon. And I will see it and share your questions and comments with the panelists. Today's session is entitled, When Bearing Witness is Too Much to Bear. And it is my extreme pleasure to introduce to you our leader of the panelists today, Dr. Donna Gaffney, who is a Rutgers School of Nursing alumna and an expert in dealing with grief and trauma. Dr. Gaffney will introduce her co-presenters today, Dr. Pipchick and Millie Elia. Dr. Gaffney, welcome.
Thank you so much, Dr. Morrow. I appreciate it. And welcome to all of you. For those of you who are returning, we're really happy to see you back, or see in quotes. And Millie will be joining us at the end of the session, and Peg is listening today. You'll hear more from her next week. So today, we are going to be talking about trauma. And I'm sure that you are all very familiar with what I'll be talking about. And today, the focus is really going to be somewhat psychoeducational. I'm just want to, I keep telling, there we go. Keep saying, I'm always being told that the WebEx is just a little slow. So I get a little impatient. It's just a little bit about the bios for the individuals who are involved in developing this program. And before I begin, I want to check in with you and ask you, what did you do for yourself this week or over the weekend? How did you take care of yourself? Just, you don't have to respond to us, but just sort of write it down on a piece of paper in front of you, and you know, as long as there's one thing that you did, that would be great. So today's title, which I've found very, I've always found provocative, that when we bear witness, and when does bearing witness become too much for us to bear? And today we're going to name trauma and traumatic responses yourself and in your environment, and also recognizing secondary trauma. Now, you may remember that on the website it said vicarious trauma, but I am titling it secondary trauma or secondary traumatic stress because that seems to be a better fit for what we're going to be talking about. And also, how do you know when to ask for help? And that's something that we aren't always really good at in our profession. So first, just a little bit about terminology. You've heard the words stress, crisis, and trauma. And what happens is that when something such as 9/11 happens, suddenly we all begin to use the word trauma. We're traumatized, we had a traumatic response, but there really is a very significant difference between those three concepts. So stress causes a physical or emotional tension. It can be short-term, it can be chronic. And when we respond to stress, we begin to have some physiologic reactions and some emotional reactions. But once the stressor is removed, those go away. A crisis is a temporary disruption in how we cope with different situations. And maybe the problem-solving skills that we've used in the past aren't working as well because of this challenge that we are facing. So once we handle that, and this is based on Kaplan's work, once we handle that crisis and we become more comfortable and we pull up new coping mechanisms, then we return to a normal state of equilibrium. The crisis event passes. Now, hopefully, we learn from crisis. That's one of the things that when, in psych mental health, somebody comes in to the office and talks to me about a situation that they're going through, one of the first questions I ask them, has anything like this ever happened to you before? Because it'll give me some insight into whether they are, in fact, approaching this in a very new way, or if they've had some experience before. And finally, trauma is actually a much more extreme version of a stressful event. Sometimes it's perceived as life-threatening. It usually evokes negative emotions like fear, helplessness, terror, physical responses and reactions, and emotions can last actually past the event, the traumatic event, if it's a one-time event. And the memory lingers on, and that sort of has a lasting quality to it. In 2013, the DSM-5 was introduced, and the authors actually revised some of the trauma information, and it used to sit within the anxiety category, and now it's in a separate category that just relates to traumatic experiences. And they added something new, which I think is very relevant for us. And that is experiencing repeated or extreme exposure to aversive details of traumatic events. They can be ongoing. For example, first responders, police officers, and I think healthcare providers. And certainly some of the things I've been hearing from clinicians on the front lines who are dealing with emergency rooms that have now become ICUs, and ICUs that are over capacity, and very sick patients in the hallways, that this is very different than anything clinicians in those areas have ever experienced. And we'll talk more about how that affects the way we cope with things. Sorry. All right, so let's just think about memory for a minute. How do we process information? The cortex gives sights and sounds meaning from what we have learned in the past. So that's sort of where all that information is stored. But when we take in sights and sounds through our eyes, through our ears, it first goes to the thalamus, and then it goes to the alert center on the cortex. So this, the red almond-shaped object in the center is the amygdala, and that is the alert center. And it lets the body and the brain know if danger is present, even before we can comprehend it, even before our cortex tells us there's something to worry about. And it does trigger the fight or flight response. I'll talk more about what that looks like. Interestingly, smell and touch go directly to the amygdala, and it brings on much stronger memories of a frightening event. And that is why if you smell something that reminds you of a traumatic event that you experienced, that smell will immediately recall all of those memories. And this is why Vietnam soldiers, when they would go past a restaurant that served food from Southeast Asia, and they could smell lemongrass, they would if they had a traumatic experience, they would feel that trauma surging through their body because the lemongrass smell reminded them of being in Vietnam. And I don't have to tell you that what is going on right now in the ICU, in the critical care areas, and even in all other areas where there's lots of different cleaning solutions being used. I talked to one client who said that she could not use Lysol anymore because the smell just triggered a traumatic response in her. So that's a little bit about how the brain works, and we're going to talk about trauma. But how do we remember memories? What do we recollect? If the if we're trying to recall something and we're in the situation that is similar to what we've been in before, when we had that first memory laid down, it will be easier to recall. Increasing levels of arousal direct our to the central features of that event, and that's called classic weapon focus. And that means that I've done a lot of work with survivors of sexual violence. And if that person said, if she or he is asked about trying to remember what happened during the sexual assault, they may only be able to tell you, I could only feel this object in my back, and I think it was a gun, or I think it was a knife. Now, because they didn't see it, doesn't mean that it wasn't a gun or a knife, but it means that that's the only part of the experience that this person focused on. So it's a really powerful way that we, pull the peripheral features disappear, and we focus primarily on the that weapon or something else that's similar to a weapon. Flashbulb memories are another interesting way that we remember different parts of our experience. It's a very vivid, detailed recollection of circumstances of the receiver of the information that's surprising and important. And of course, the classic flashbulb memory that people have is Jackie Kennedy leaning over. I know that a lot of you are too young for this, but for those of you who might recall, Jackie Kennedy leaning over and pulling the Secret Service agent onto the back of the car after her husband was shot, President Kennedy was shot. And the memory for the directly experienced shocking event is more stable than a flashbulb memory. In other words, if you were there on the green in Dallas, this memory would be very strong. But if you just heard about it or saw pictures of it, it wouldn't be as strong. So what is trauma? It's a shocking, frightening, dangerous event that exceeds the standard parameters of our human condition, and it affects us emotionally. Sometimes, and there are a number of criteria that the DSM talks about, and I'm using that here to help really illustrate what trauma is, not necessarily talking about PTSD, which I'm going to just briefly mention at the end of the session. It can be directly experienced, it can be witnessed. You can learn about the event from a family member or a friend, or it can be experienced firsthand repeatedly with extreme exposure to details. And I think this is where, and again, this was revised in 2013, this is where healthcare providers are really coming to terms with what this means to be in a critical care setting with many COVID-19 patients in your area, and you just see this the sensations wash over you, the sounds of the machines, the calling of people, and some people have actually said it's actually very quiet. It's because there aren't any people talking, none of the patients are talking. They might be prone, you can't see them, everyone is covered up with layers of fabric and paper and shields and masks. So there's this landscape that is completely unknown to us because we've never had to witness anything like this before. So how does our brain now process fear? I just mentioned how our brain processes memories, but fear is a little bit different. There's two ways that it gets processed. One is the shortcut, and it's sort of the all points bulletin that that we're in danger, and that goes right into the thalamus, into the amygdala. And the amygdala responds and tells us we're in danger before we even know it. And it can be milliseconds. So you see a snake, you're not sure what it is, you see something moving, and all of a sudden you are in a hyper alert scenario and you want to get out of there quickly. But if you know a lot about snakes and you collect snakes, and you can identify them, you take the high road, and that is information is analyzed with cortex and it begins to process it. So you see something moving and you don't say, oh, I've got to get out of here to save my life. You say, oh, that's water moccasin. And it begins to shut off that fear response. So information really does make a difference. So the high road, as I mentioned just a few moments ago, is when it goes in through the cortex and then to the amygdala. Now, the amygdala, really alerts the rest of our body. The neurotransmitters wash over us and can make those connections between the neurons and causes us to have a number of physiologic responses: racing heartbeat, fight or flight or fright response, and digestion shuts down. So when you become fearful or upset, or you see something that evokes that fear response, there's a reason why you feel sick to your stomach. And some people actually even vomit because digestion has completely shut down. There are some other parts of the body that absolutely don't function at all during this fear response. And that is because everything that you are experiencing has to go really to one cause, excuse me, one particular response, and that is one goal: survival. So you freeze. It's an instant check. You identify the location of the danger and if you can escape. And that is why the phrase "deer in the headlights" is so popular, because our pupils are dilated. We're beginning to take in all kinds of information. And we actually don't recall doing that. It happens so very quickly. Next comes fight or flight. And that's when the danger, we either respond as we fight or we run away as fast as we can. Now, there isn't any particular reason why people respond one way or the other. If you've had a lot of training, as in law enforcement or the military, you will most likely fight because you've been trained to do that. You also take in the location of the danger, and that at that moment you say, well, there's the danger between me and the doorway that I'm not going to be able to get through there, so I'm going to fight. But if the doorway is on your side, you are going to try to escape. So it doesn't really depend, it doesn't really factor in to whether it's a choice that you're making. Again, your body and your mind completely responds in that way. And again, referring back to victims of violence, they very often say, why didn't I fight back? Why didn't I fight back? And they blame themselves. But the fact is that their bodies and their brains told them what to do in order to survive. Now, once that danger or the threat passes, your blood pressure returns to normal, your respiratory rate drops, your heart rate drops, and the hormone flow returns to normal as well, and you go back into homeostasis or equilibrium. So what does trauma do? It causes changes in our physiology: tachycardia, increased respirations, dilated pupils, dry mouth, shaking, and dizziness. Sometimes you'll recall, if you're in the middle of a code, for those of you who are in the clinical setting and especially in very critical care areas, the code actually alerts your body to respond to these things, and you might feel that. Now, in many cases, that really helps you function better. And their emotional processing is also disrupted, usually with a negative emotional state: fear of dying, fear of losing emotional control, emotional distress, horror, disgust. Any of those negative emotional states are certainly possible. And that, again, is very normal. It also disrupts cognitive processing. Your memory becomes fragmented, out of sequence. You can't attend or focus on certain things, and time is disoriented. Is distorted, and you may be disoriented as well. And that is, again, very, very common. This is what people do when they experience trauma. Now, a lot of people think that it's a great idea to just not talk about things. And I'm here to tell you that that's not a good idea. A number of research studies have shown that suppressing memories of any type are going to cause a rebound effect. Although it seems like a good idea to get rid of painful thoughts and a reasonable way to cope, that is absolutely not going to help. It's going to make things worse. You're not going to be able to forget. It will actually make things worse. So some people have been collecting some data. Stanford University has, in the first week of March, they started to collect data on what their clinicians were feeling in the clinical area. So the causes of anxiety of those people working with COVID-19 patients, number one, access to PPE. It's something that we hear about all the time. And actually, that is number one. And then exposure to COVID-19, taking infections home to the family, unavailability for rapid testing, uncertainty of organizational support, either personally or with your family, with your colleagues, access to childcare if you have a family with kids and your hours are going to be increased in number of hours and school closures. Oh, by the way, and I just want to mention this, Anne-Marie mentioned it last time, but if you have any questions, please ask them during the session so we can really address them as they come up in the presentation. So please feel free. Material support, food, hydration, lodging, transportation. A lot of communities have been giving their local restaurants business by ordering food for the hospitals. And it actually broke my heart yesterday to hear that one of our bagel shops here in Morristown was going to have some really hard times staying solvent. And it's because 3 weeks ago, everybody was ordering bagels and sending them to the hospital. And now that's not happening anymore. So I think we have to be keenly aware of how to support those people working in the hospital at all levels. Also, another source of anxiety is this ability to provide competent care if deployed to new clinical settings. And I've heard that from people who usually work in the ER that now have to go to the ICU, or people in OB who have to go to the ER, physicians and nurses asking, and advanced practice people being asked to do work that they have not done before. And so it's a matter of retraining them. And I believe that Cedars-Sinai actually ran a course for their residents so they could do nursing functions. So I thought that was kind of interesting. And also lack of access to up-to-date and accurate information and communication. So you feel as if you are really operating in the dark and you don't have the information that you need. Not only that, you might even question or challenge if the information is accurate. It really begins to become very, very difficult for people to really understand what is happening. And that contributes to that anxiety. Now, I talked about the trauma. Well, trauma leaves us with a traumatic stress response. And you'll hear all different kinds of descriptions. There's compassion fatigue, which I'm not going to talk about. We sort of addressed empathic distress last week, but there's secondary traumatic stress, there's primary traumatic stress, there's all of this language, but just stay focused on, if you have a traumatic experience, you are likely to have a traumatic stress response. And what do those symptoms look like? They're varied, they're complex, and they're unstable. And they really can use being so incredibly exhausted, confused, you could be sad, you can be anxious, you can be agitated, numb, dissociating, disoriented, depressed, physically aroused, or have a blunted affect. Any and all of those can happen, and they are commonly experienced. There's nothing um, psychosomatic about this. There's nothing that is diagnosable. This is what people experience. And in fact, if someone is going to be diagnosed with acute stress disorder or post-traumatic stress disorder, we are still way, way too early. You don't diagnose PTSD until at least 1 month and up to 6 months after an event. So right now, everyone is experiencing traumatic experiences, the traumatic events within their clinical settings. But there is also time for you to escape from that. And I'll talk more about that. Now, we've talked in the past about how COVID-19 is something very new and very different than we've ever experienced before. And yet, there's a lot we can learn from the SARS epidemic in 2003. A number of studies found, especially in Toronto, because that's where the North American epicenter was of the SARS epidemic, significant distress in 30 to 50% of healthcare providers. And what were the causes of that distress? Quarantine, fear of contagion, perceived stigma, treating colleagues who have SARS, concern for family health, and social isolation. So you can see that it really is very similar to what we're experiencing right now. The major difference is that SARS was a very different virus than what we're experiencing right now. It wasn't as fast moving. It took longer to move from person to person. And also there was not the symptoms, when the symptoms appeared is when the virus was transmittable. Not now where as with the coronavirus, where there's sometimes unknowns, symptoms are not visible. So what some of the researchers found in Toronto is that fostering individual resilience and fostering organizational resilience were actually the best approaches. And part of the individual resilience is actually building your own set of skills that relate to resilience, but also practicing psychological first aid. And I'm going to talk more about that at the end, because I think psychological first aid has been used after disasters and originated at Hopkins and has really been also, you can download the whole manual on the National Child Traumatic Stress Network. But the fact is that it is a basic 5-point way of helping people who are in these very, very difficult, very emotional, very traumatizing situations like disaster, like terrorist attacks. But now we are beginning to see how it can be very useful in healthcare settings. Interestingly, very little written about how nurses can be the beneficiaries of psychological first aid. And it might be that the important thing for us to do is practice psychological first aid on ourselves with each other in the clinical setting. Now, secondary traumatic stress is a little bit different. I use the term vicarious in the objectives on the website, but after rethinking it, I decided that secondary traumatic stress is really more appropriate. Vicarious traumatization was something that was developed for clinicians and therapists working with victims of violence and trauma, that by just listening to the clients talk about their situation, it could be traumatizing to the clinician or the therapist, him or herself. But secondary traumatic stress means that it's not only the people on the front lines, but people who are in the trenches, the people behind, people in the classrooms, and people at home who might be listening to the kinds of stories that you are bringing home. But I also hear that a lot of people are not bringing home stories because you don't want to upset family members. So it's really important that you find someone to talk to. And the important thing to remember is that you don't have to rehash all the details of the trauma and what you saw, but really just talk about how you are doing, how you are feeling. because there's a lot of, as you share your details, you can actually cause other people to get alerted and aroused by hearing and just imagining those details. So this secondary traumatic stress actually parallels the DSM-5 symptoms of PTSD. Intrusive re-experiencing, that's when you are, home or in class, and all of a sudden you have an image of something that happened in the unit, in the critical care unit. You also try to avoid anything that causes you to think about or causes you to have those experiences. Or you can have alterations in arousal and reactivity. And a number of people last week talked about the anxiety that you sometimes feel. And that is actually, when that anxiety carries over, that is one of those symptoms that parallel what the PTSD symptoms. There's also alterations in the way you're thinking and in your mood, and even dissociation, where you actually just zone out and don't think about anything. The classic example of dissociation, and we've all done this, you're packing up to get all your things ready to go to school or to work in the morning, and you take your keys and your wallet and everything else, and then you drive to work, or you're taking the subway or however you're getting to work, and you get to work and you have absolutely no recollection about how you got there. You don't remember seeing the traffic lights or stop signs, crossing the street, nothing. It's because you have almost dissociated from that experience. It's similar to what happens. There's also indirect exposure to traumatic stressors or stress reactions that extend beyond the symptom categories, and that's moral distress. And that is, you are so distressed that you can't do the job that you were trained to do, where you were educated to do, because of any number of factors. Maybe there's not enough supplies, maybe there's too many patients, maybe the patients are far too sick, and there's just no way to really capture the moment and to do what you would feel good doing that would give you that compassionate sense. So moral distress, decreased empathy. And I think this is a real challenge with the kinds of patients that you all are seeing. You don't necessarily see their faces. We don't know what they look like before they came in to the critical care unit. They have, maybe they have a ventilator tube, maybe they have tape on their faces, maybe their hair is covered. I call it the ICU, CCU camouflage. We wear, the nurses wear it, clinicians wear it. We're all covered up, that we can't tell who's who, and imagine the patient feels exactly the same way. So that doesn't help us with our empathic response. One of the ways that we feel an empathic response is when we see someone that we can relate to, that reminds us of someone in our lives. And now that patients are all covered, that we may not be able to have that very same experience. So it decreases our ability to empathize. Also, a diminished sense of professional self-efficacy. We just can't imagine how we can get the job done. And feeling stigmatized, to feel that we can't do this work, and it's almost brings a sense of shame to us because of the stigma that's related to this, and that stigma carries over outside of the hospital when people don't treat, people come from across the country to help in the epicenters here in New York and New Jersey, and they can't get a place to stay, or they're not allowed to stay in a building, and I believe I spoke about this last week as well. So the stigma is the same feeling. And I can recall, and I'd ask you to think about this for a moment, that you've been in a social situation and people say, "Oh, what do you do?" And so I, in my situation, I would say, well, I work with victims of sexual violence and children who've lost a parent and people who are traumatized. And it's like they immediately take 5 steps back, and they like, oh, they don't understand how we do the work. And sometimes they say that, oh my gosh, how can you stand it? How can you? So it begins to tell us, we begin to hear the message from other people that what we're doing is so difficult. And when they say, I don't know how you can do it, that's the time that you actually explain how you do the things that are very important for your own professional um, growth. So when we are going through all of these very difficult secondary and primary traumas and secondary traumas, we need to stay balanced in the situation. So how do we stay balanced? Well, we have to trust, and we actually have to address the dependency issues as well. We have to feel safe. We have to have a sense of power to know that what we're doing is within our control. We have to have our self-esteem and intimacy, um, independence, and a frame of reference. Now, let me start with the last one, the frame of reference. One of the things that I think happens when we work in very difficult areas, challenging areas, that we begin to see the whole world like the patients that we see. And in my work with children who are grieving or victims of sexual violence or any kind of violence, you begin to see all the world as those kinds of patients. And it changes the way you see things, and it doesn't help you stay balanced. So you have to reframe your reference points and know that not everyone is having that very same experience as the patients that you're seeing. I know that we hear all the time that 80% of the people who are experiencing COVID-19 go ahead and heal, but of course we only hear about the patients who don't heal that well and struggle and are put on ventilators and may ultimately die. Independence is when you really can look at how you take charge of the things that you are doing in your practice and in the way you practice, so that you find that balance, that you don't want to be dependent on other people, that you really want to say, I can be an independent person, I'm educated, and I know how to do this. And I think that's something that when you're maybe transferred to a different unit and you're now taking care of very ill patients, you may not think that you can do it, but you actually can. With orientation, with guidance from other people, it's not like you're asking other people to tell you how to do it. You're asking for their suggestions and their guidance. And I've heard many people say that they have a quick sort of a process of educating people on their units. Intimacy really addresses how we react to other people who we are our colleagues, our family members. And again, I talked about this last week. You really want to make sure that people who you're talking to are present for you and are able to listen without judging you or without trying to change your mind about doing the work that you're doing. So that means finding people that really can sort of fit with what your needs are at the time. Likewise, you can then pay attention and trust their needs as well. Esteem, self-esteem, it's all about, am I doing this the right way? Can I do this? These are the kinds of issues that challenge us, that you want to make sure that you are reflecting and reframing and saying, when you have that sensation, oh wait, I don't know if I can do this, then you reframe it and say, I can do it. I learned how to do this. And this takes a lot of cognitive preparation to be able to say these things to yourself. Safety is just knowing that you feel safe in the setting, and that has a lot to do with other people in your clinical setting, and also other people that are in your home or your living, your fellow students, that you really want to be able to feel that somebody's got your back. And again, trust and dependency, again, not being over dependent and being able to trust the colleagues that you are working with. So what are the risk factors for secondary trauma, secondary traumatic stress? A personal trauma history. If you were 5, if you were 8, if you were 10, if you were 15, if it happened last week, be aware that a personal trauma history can affect the way that you respond to new traumatic settings, new traumatic events. So it's not that you are going to struggle with it more, it's just be aware of that. And many times those situations will come roaring back when you least expect it. And it's because maybe you thought you had dealt with it, but then it comes back. And so you need to address that. And that's just something that you keep in back of your mind. Your level of education. There's no question that psychoeducation is really the most important thing that helps anyone dealing with any kind of traumatic event or traumatic situation. Um, the more we learn, the better we're prepared. And we rely on that. And we go back to reading articles and sharing information with other people and keeping up with all of the information that's out there. And for example, many journals are now offering free um, journal articles, free PDFs. There's a lot being written now, and I just urge you to read as much as you can, because the more educated you are, the better prepared you are, the less likely that you're going to have some untoward reactions to a traumatic situation. Trauma training, the very thing that we're doing today is actually called trauma training, so that you know when you're feeling anxious, when you're reacting to something, when you start to sweat, when your pupils dilate, when you have a dry mouth, that's because of the way your body is responding to a traumatic event. It's not because you're going crazy or you're having difficulties in areas that you've never felt before. I can tell you that every single clinician who is working with COVID-19 patients and those who are working in backup settings, they're all feeling some degree of trauma because of how unusual this situation is. Supervision is really important. Someone you can talk to about the way you're responding, and just a checkup from the neck up, as some of my clients like to call our sessions. That it's really important to talk to someone about what your experience. And balance in your clinical population. I know that this is impossible right now. You don't have a lot of choices as to how many patients come into your clinical setting and how you're reacting to it. And you can't ask to go to a less critical care area because of the nature of the needs of your organization. But when you have a chance to balance that clinical population in the future, know that it will be very helpful for you and give you some respite.
Dr. Gaffney, we do have a question from an
Okay.
attendee
Okay.
who's thanking you for mentioning stigma. Can you please speak more about self-stigma and perceived stigma in the workplace and in the community, and also
Sure.
about what nurses can do to address this?
Well, I think that as I mentioned in my own personal experience, when you're in a social setting and someone asks you what you do, and then you tell this person, there are a lot of people who don't say anything. They don't. Just sort of gloss over that information. That doesn't really help you at all. But in this situation, because we're learning about COVID-19 and coronavirus every single day, that people do not understand, and they're ignorant of the facts. And let's start with the community first. So you are in your apartment building, or you're in a outside setting, and people know where you work. They know that you're a critical care nurse. They know that you're working with patients. And then you see them move away from you, and they are scared. And there isn't anything that is going to help them appreciate that there's nothing to be afraid of, because there is a lot to be afraid of. We hear every day about how we've gone from 3 feet to 6 feet to 13 feet to be near other people. So the world around us tells people to be afraid of us. So you're not going to get some respite or some comfort in being able to explain to them that you're not a danger to them, because that's how they see you and you won't be able to change their minds. So that's for the community. Now, for family members and for friends, you can be a little bit more forthcoming with them, and you'll also feel the stigmatization from some of your non-healthcare friends, and they'll say, well, you might notice that they don't call you, and of course, no one should be socializing at this point in time, but they may pull away from you. And the best thing they can do is acknowledge what they said, what they're doing, and just say, I can see that you're kind of afraid to talk to me, or you're a little concerned about talking to me because of the work that I'm doing. Um, and we should talk about that. So you call out what you see happening in relationships with them. I can't explain if somebody cancels a lease, or we don't have any control over that. So the best way to deal with that is to just say, it's not within my control. I can't change it. I'm going to move to another possibility, and I'll take action in a different way, because part of this is recognizing what you can change and what you can't change about the way people talk to you and the way they interact with you. And also, if there are people that are really reacting to the kind of work that you do, don't don't interact with those people. Again, it's finding the people that are supportive to you, who can be present with you. And again, I always suggest that people talk on the phone as opposed to writing an email or a text, because I think hearing another's voice helps to break through that stigma. And also, I think the self-stigmatization is also important to look at. There probably is 100 times over a period of not so many months where I've said, I can't believe I'm doing this work. I can't believe I'm, you know, taking these kinds of actions, and you begin to blame yourself for making these choices. But just let that go, reframe it, and say, the reason why I'm doing this work is because I believe it is really important to me. I read a post the other day from a friend of mine, and he lives in Brooklyn, and he has a friend who is a nurse. And he wrote this long, long post about her experience, which I thought was fascinating, that he then talked about it. And the responses that he got from other people were really wonderful. And I think that when people post on social media, you do get responses that are very powerful and very supportive of you. That's where you put your energy. That's where you take the time to really interact with those people, whether it's on the phone or in a social media post or in an email. That's where you'll get that support that you need. So we can't necessarily remove the stigma because of all of the information that is out there right now, but we can continue to interact with people that are supportive to us. And that helps us then remove some of the stigma that we have, that we feel for ourselves. So I hope that answered your question.
Thank you, Dr. Gaffney. That's very helpful, because there was another comment asking about self-stigma. And then there's another question. So the comment is made here that the psychological needs related to trauma are similar to Eric's stages of development and Maslow's hierarchy of needs. How do you think these theories intersect with understanding secondary trauma?
Well, there's so much written about secondary traumatic stress that we tend to, you begin to take the theories that make the most sense to you. So, of course, you think about Erickson's stages of development, and when those stages are not accomplished, that's a stressor. And that can then cause people to have a more profound response, trauma response to it. Same way with the hierarchy of needs. So I think it's how they all fit together. I like to think that if you had theories, different theoretical frameworks on different pieces of lucite, clear plastic, and you laid one over the other, they all can exist simultaneously. It's just that you may really respond and attend to some of the issues at different times. We certainly know that with Erickson's work, that not being able to accomplish those goals is very stressful and can lead to more difficulties later on. I hope that helps. So just take a breath and another breath, because now we're going to talk about fixing things, and I'm not going to cheat Millie out of her time. So I'm going to spend just a few more minutes talking about resilience, and this will all be in the slide presentations. We really need to build our resilience. It's not something we're born with, it's something that we can cultivate. And I really like from a Walsh's discussion of resilience as the ability to bounce forward from adversity, strengthened and more resourceful. I think that's really important. It's our ability to cope under adverse circumstances. It's not a personality characteristic, it's a dynamic process. It's not static, it can change. The quality found at all levels, individuals, families, workplace, and communities. And I just want to share with you that this is the rowan tree, which is native to Ireland. And it is one of the most resilient and strong trees that we know of. I like to think of nurses as being similar to the rowan tree. Self-assessment, really important. Look at your symptoms. How are you reacting? Write them down. Recognize empathic distress, triggers for your trauma. Identify and use your resources. We've been giving you resources every single week, and we're going to continue to give those to you. Again, looking at your personal and professional history, see if there's previous traumas. Action goals, learn and practice these arousal skills, learn grounding skills, and the ability to contain some of those emotions. Make a contract with yourself, resolve the barriers to success, initiate conflict resolution, and look at a very supportive aftercare plan. And psychological first aid, so important. It's about validating what people are feeling, recognizing their basic needs, looking at problem solving, providing accurate and timely information, connecting with support systems, providing education, reinforcing strengths and positive coping. And this is something we can do with each other. That every single person on your unit can begin to practice that. And I have a resource at the end of this where you can actually download the PFA, different kinds of actions that you can do. Organizational resilience, really, really important. And this, again, the SARS research pulled this up. Hospitals, clinic, public health organizations, schools, universities, you know, we heard the word trauma-informed. We need to have trauma-informed organizations that are also resilient. And just some of the things: establishing reserves, effective leadership, training and education, characteristics of magnet hospitals, and organizational justice. And the date of this paper was 2008. Well, I'm not sure that we've really worked that hard on organizational resilience. This is a great table from the individuals at Stanford that looked at what people needed. And I think if you just look down the column, hear me, protect me, prepare me, support me, care for me, and then the desires, the concerns, and the key components of the response. That is what we need to do for nurses and for all of you in the clinical setting. Prevention is so very important. Life balance, relaxation, humor, balance, boundaries. You know, when you go home, we want you to shed your clothing, your attitudes, your emotions, your thoughts about work, and enter into the safe zone of your apartment, your home, whoever is there with you. Get support, coping. Don't be a sponge. When we completely take on others' suffering as our own, we are at risk for empathic distress. We feel threatened, we feel overwhelmed, and it could lead to burnout. We want to be receptive to other people's feelings without absorbing those feelings. And finding sanctuary, no matter where it is, a corner, a window, a hallway, make it your own sanctuary from outside threats. And finally, I want to tell you a little bit about post-traumatic growth. And, we always talk about, well, this trauma is so difficult, I'm going to be scarred for life. Not so. Post-traumatic growth does not just deny the distresses or the difficulties, the challenges that you feel at certain times, either during the traumatic event or afterwards, but there is growing evidence that tells us all that growth does occur. And it demonstrates really our unique capacity for many people to learn and grow from extreme adversity. And I'll leave you with one thought. When I was teaching at on a PEDS unit, I saw a woman who just was remarkable in how she was caring for her little girl with leukemia. And I was young, I will admit that. And I said to her, wow, it's just amazing. I'm so in awe of what you do. I don't know how you do it. And she looked at me square in the eye and said, you would do it because that's what we do. And I think that was such a positive response from her, that we do what we have to do. And here's the psychological first aid for healthcare providers. And you can access that. And please let us know how you're doing. And now, Millie, you are on.
Thank you, Donna. Good afternoon, everyone. Today, I wanted to offer an exercise that can really complement what Donna was speaking about in terms of keeping us in the moment during challenging moments associated with COVID. The exercise I wanted to go through with you today is really made up of two parts, combining our breath with our five senses. I always include the breath. By breathing slowly and deeply, you're able to really tap into your own portable tool that you can use anytime and anywhere. Breathing slowly allows you to activate the part of your nervous system that helps your body to calm down, to help bring you to a place where you can think more clearly and return to the present moment. The second part of our exercise today is focusing on our five senses to help ground us. And how that works is to start with five different things that you can see, hear, sense with your skin, taste, and smell. Then notice four of each of these, then three of each of these senses, and so on. Be as specific about these as you can to make yourself really concentrate on the external factors and to get out of your out of the sort of panicked or flighty stage and feel more centered in your own body. You'll want to pay attention to things like shape, sense, textures, and colors. I'll run through a very quick abbreviated exercise using just a few of our senses combined with breath so you can get a sense of what it's like. I'll ask you, as always, to start by getting comfortable in your seat, and we'll begin by taking a slow, deep breath through your nose, feeling your belly rise. Then I'll invite you to start slowly to turn your head side to side, looking around the room where you are right now. If there's one available near you, perhaps look out a window. Notice what is far away from you. Notice what's close to you. Notice the different colors and shapes all around you. Notice the light or lack of light. Notice something around you that captures your attention. Notice a part of your body that maybe you don't usually pay attention to, like the soles of your feet, the backs of your calves. If it's comfortable to you, begin to look up and slowly look down. Continue to feel your breath moving through your body as you slowly move your head. Notice how your neck feels. When you're ready, bring your head back to center and pause for a moment. Finally, notice how this practice makes you feel. And this is something that you can certainly repeat at your own leisure and get a better sense of. A more complete exercise that joins all of our five senses with breath can be powerful medicine during potentially traumatic events correlated with COVID or any time. With that, I hope these exercises are helpful to you. Thank you. I'll return the floor back to Donna.
Thank you, Millie. And thank you, Dr. Gaffney. Dr. Gaffney, we had a couple of questions at the end. I know a few people got off. I don't know if you can take a brief minute to answer
Sure.
them.
Absolutely.
So there was a question about social media perhaps being a double-edged sword, and maybe briefly talking about that. You were talking about, I think that addressed some of what you were talking about a little bit at the end there. And then also a question was posed, does telling a person who's in distress that, quote, the situation is out of our control, end quote, also trigger a feeling of stress in that person? Is that, I guess, the question is it a therapeutic thing to say or perhaps non-therapeutic?
I think, let me do the last one first, and then I'll go back to the first one that you mentioned. I think it is important to recognize what you have control over, that you cannot, if your patient is dying, and we're going to talk more about that this coming Thursday, there isn't a way that you can actually change that outcome if that person is like moving towards the last hours of their life. But you can change the way you respond to that. And I think that that's something that we often, we focus so much on what we wish we could change that we don't focus on what we can do in response to that event. And I think that's especially important as we're working with very sick and dying patients, patients dying of COVID-19. So I do think that it's helpful for you to recognize what you can and cannot do. It's not and you sort of begin to practice saying it to yourself in a non-dismissive way. I am doing my best. This is what I am doing, but I can't change the outcome of, and then fill in the blank. Sometimes we get into organizational issues as well. If there isn't enough protective equipment that, you may not have control over that, but what do you have control over in that situation? And I think some people have taken very drastic measures when they have not had the kind of equipment that they needed, and then been penalized for it. So I think that saying it in a very specific way, not in a, oh, I don't have control over any of this, but I don't, look at your one patient. I don't have control over what his body is doing right now, but I can make him comfortable. I can talk to him and those kinds of things. So the more specific you are, the less sort of fatalistic you'll be in response to that. And Emery, could you just remind me what you said, the first part of that question?
No problem. Thank you for that response, Dr. Gaffney. It's a question about social media being a double-edged sword.
Right. Right.
Your thoughts about that?
Well, I think that if you're sharing your experience, and you have a group of people that follow you, then it is really, I think, very helpful. I think, well, let me backtrack a little bit. The reason why social media works is because you are writing down your thoughts. That's why it works. There's been a lot of research on how writing, journaling, the work of Penny Baker from Texas has just really talked a lot about how that helps you process the information. So my guess is the reason why we're seeing so much in social media now is because people are driven and really feeling very comfortable in writing their stories. I think as long as you write, whether it's in a journal or on your laptop or social media, it is fine. As long as you're telling your story, you're giving your experience. I think that there's lots of ways you can get into trouble on social media, but I think that from what I've seen, people sharing their experience, they're getting tremendous support from other people that they don't even know. And that really helps to combat the stigma that is so attached to taking care of COVID-19 patients. I would warn against anything that gets you into the political realm, because we don't know who's reading. People can see different comments that you make. I think that from your heart, you're writing about your experience. And that I think is the most important thing. But I think that if you have a group of followers, people that you may know in your face-to-face life, but not necessarily know personally, those people are a great support. But again, writing is the most important thing.
Thank you, Dr. Gaffney. And thank you also to Millie for your wonderful presentation and the calming exercises at the end. This is always very helpful. I see comments from the attendees thanking us for this informative discussion and for talking about trauma-informed care. So,
Dr. Morrow, if I could just say one thing.
Sure,
Millie and
absolutely.
I and Peg are putting together a document with all kinds of resources for
Great.
people to go for different exercises and websites for more information. So if there's anything that people are specifically looking for, please let us know. We're happy to share with you things that we have found helpful and that our clients have found helpful as well.
Thank you so much. You've been very generous, all of you, with your time and your expertise. We thank you very much. And we invite everyone to complete the evaluation forms for continuing education credit. They've already been emailed to the address where you registered for this webinar. And I invite you to join us this Thursday for our next webinar, Facing Grief and Grieving, Thursday, April 23rd at 12 p.m. You can register at the School of Nursing webpage. And thank you again, Dr. Gaffney, Millie, and Peg for your wonderful contributions. Be safe, be well, everyone, and take good care.